So my talk is on corneal topography. We are going to go over a little bit of educational stuff and then delve into a little bit more practical stuff. So my basically corneal topography, what is it, why do we do it, and what do the numbers mean? And then we'll go over a little bit of other stuff. So corneal topography is used to measure the shape and thickness of the cornea. So we can tell whether a cornea is regular or irregular astigmatism, if it's thick or thin, and we can monitor for changes in shape, which is especially important for ectatic disorders, just like keratoconus and post-LASIK complications, those kinds of things. It can also help us monitor Fuchs dystrophy because it tells us about the thickness of the cornea. So it gives us a lot of information. We do it for a lot of different reasons. Various techniques and machines are used, have been used, and are currently used. The Placido's disc type of topography uses concentric rings, and you can see a picture of it on the third page. Basically reflects these rings off the cornea, and if the rings change shape or distances between them, we can tell there's an irregular spot. And there's some examples down below of some irregular Placido's discs. Top one is normal, where it's all concentric and even, and then just kind of gets worse from there. The other types of machines are a scanning slit technique, an orb scan, which kind of basically sounds, it takes a bunch of pictures as it goes around, which is similar to the Pentacam, but there's an additional component to the Pentacam. Scanning slit technique was kind of the right before we got to the Scheimpflug imaging, which is what the Pentacam is, okay? The Pentacam uses Scheimpflug technology to create reports. Basically, the Pentacam has two cameras, and they're tilted, and you can see on the, I don't even know what page it is, 1, 2, 3, 4, 5, 6 page, I go into a little bit more about the Scheimpflug imaging, and basically it has to do with getting a clear image all the way around the cornea. And again, it takes a lot of different segments, gives us thousands of different points for us to be able to analyze the cornea's thickness and shape in as much detail as possible. Let's see, why do we do it? Again, I went over this a little bit. Keratoconus is probably the one that everybody knows about. Irregular astigmatism. Keratoconus is a form of irregular astigmatism. And we do it for refractive surgery and preoperative for cataract surgery, so that the doctors can screen for that type of irregular astigmatism, so they can make an educated decision with the patient about what they can expect after surgery. If they have a significant amount of really irregular astigmatism, they're not going to benefit the same way a normal regular astigmatism patient would from the upgraded toric lenses. So the doctors tend to either tell them ahead of time, hey, we can correct your astigmatism, make it less, but it's still not going to be perfect because your cornea is not perfect. And then otherwise they can say you shouldn't even spend the money. You're going to have to wear contacts afterward. It's not worth your money to put in that toric implant. So refractive surgery, pre-op cataract surgery, post-operative PKP and DSEC. PKP, again, you're dealing with an irregular cornea that has lots of sutures in it, and the doctor's aim is to try to remove sutures strategically so that when we're all done, we have as round of a cornea as possible. So the corneal sutures don't have to come out. Usually they do, a little bit at a time, but say they're magically right after surgery, cornea is totally round and it never has to be adjusted. Those sutures can stay in unless they break. The most of the, I mean, I don't know if I've ever seen that. Every other time, you're going to get some irregular astigmatism, and the doctor's going to try to slowly remove sutures. Say the cornea is really tight this way, we're going to remove sutures to try to flatten it out, make it more round, okay? Which is why we do pentacams for PKP patients every time they come in, so the doctor can say, oh, it's moved, now I can remove these 2 sutures. Oh, it's moved, I can move these 2 sutures. Or, I don't have any more sutures left to remove in that particular area. We're going to leave it as it is, okay? And then the patient will just need glasses, contacts probably, after their surgery for best corrected vision. So super important for those PKP patients. DSECs, we do it mostly just to look at the thickness of the cornea. There's some other corneal imaging like Visante that's really, Visante and cell counts are really helpful for post-DSEC patients, but also with DSEC patients, you can still do Pentacam to determine if the cornea is swelling at all. Make sure that graft is working well. Pterygia scars and Salzmann's nodules, these are all things that affect the shape of the cornea because they're growths on the cornea, pushing on the cornea in weird areas, so it's again inducing irregular astigmatism. This lets us see, okay, is it significant to the patient? Is it affecting the central part of their vision? If it's not, probably not really going to bother the patient unless it's, you know, pterygium can irritate the eye and just make it uncomfortable. But besides that, we don't have to do anything unless it's bothering the patient in those cases. It helps to aid progression. Again, we can watch and see if the pterygium's moving, progressing, and then yeah, so that's a reason we do it for pterygium, scars, Salzmann's nodules. We're just looking for, is it affecting the vision, causing some irregular astigmatism. And then Fuchs, we talked about that, thickness changes we can monitor. What do the numbers mean? Why do we use the reports that we use? If you can look at the pictures there, the first one on the left side is a nice, perfectly symmetrical bow tie pattern. That's what we're looking for a regular astigmatism. And alternatively, the images next to it are all different forms of irregular astigmatism. Specifically, the 4-map refractive gives us 4 different maps. We have an axial map, a elevation for the front and the back surface and of the cornea, and a corneal thickness measurement. Okay, lots of information just on one page. The axial map itself is used to give us an idea of the shape. We look at, okay, is the image that we're seeing symmetrical? Does it have that nice little bow tie pattern? Is it even on both sides? Some things that we pay attention to, superior and inferior keratometry measurements should be about equal if you have a regular astigmatism. And then also the axes, so the little red and blue lines, should line up with each other. If you see a bunch of broken ones, some red ones over here, blue ones over there, that's an irregular cornea, okay? On the next page, you will see some examples of the different type of patterns that you can see. Obviously the regular one is the symmetric bow tie. Right next to it, the middle two, the asymmetric bow tie and the skewed one are both pretty common to see. I should caution though, these 2 patterns can happen if the patient's off center. So if the patient's not perfectly focused straight ahead, straight into the machine, you can get an irregular looking cornea just because of where they're fixating, okay? And then of course some inferior steepening, which is our big red flag for keratoconus. There's some other maps that we look at for that as well. Risky factors for an abnormal cornea with regard to axial maps. If Ks are over 48, if there is some sort of angulation, weird shape, okay, if the astigmatism's over 6 diopters, if there's a difference in inferior versus superior measurements of more than 1.5 diopters, okay, and then also just looking at it, is it symmetrical, is there asymmetry, okay. The next map would be the anterior and posterior elevation maps. These are creating images, elevation, just like mountains and valleys, compared to a perfect sphere. So it's the best fit to the sphere that we can get, either posterior, anterior. That's what where are the peaks and valleys in this cornea. With regard to that, you're looking for this nice hourglass shape again, okay? If you are abnormal shapes in the slide below can be islands of depression, islands of elevation, and kind of, again, wonky. They call them tongue-like projections. Just not normal looking hourglass shapes is what you're looking for in an irregular cornea. Regular should be fairly symmetric. Obviously the picture up top is the perfect example, but you can notice on the top left of the slide, you can see that it is also normal, but it's just a little tilted, not perfect hourglass. That's still normal as long as there is that connection and it looks fairly symmetrical. Okay. Normal pachymetry is the last map on there, and it should be kind of concentric, starting with warmer colors in the center and moving its way out to darker colors. So that's because cornea is thinnest in the center. Gradually, normal corneas gradually move to be thicker, okay, from the center. It's usually green to yellow in the center, and then again moves further to blue, purples after that, okay. Displaced areas of thinning. So if you saw that, the warmest areas should be right in the pupil area of the map. If it's off center from that, that's very worrisome for some sort of ectatic disorder, just because that's where the thinning's happening off center, which can be irregular astigmatism, right? If you're looking through different curvatures, that's not going to help your vision. So any questions about any of that, just to start with? I know we went through it really fast. Okay. The Balin map that we sent is important more so for ectatic disorders than anything else, which is why we don't really need to send it for our just routine cataract pre-op stuff. It's more looking into, is this patient at risk for ectasia? So their maps can be pretty normal, or, you know, look good, but then we can send this Balin and it gives us a little bit more detail as to is there thinning, is compared to a normal eye, does this look normal for that patient? They compare back and front elevations to that best fit sphere, and does a difference mapping between the two. So it kind of does what the front and back elevation from the format refractive, takes that information, does the math, okay? And it also creates a D value, which is Dr. Mayer looks at specifically for help determining risk for ectasia and keratoconus. It's in the bottom right-hand corner of the the Balin map, and you can see on that initial slide I was going over, down in the corner, it's nice, it's white, that's your D value, and in the next one, there's a red area there, okay? And you can look at the two maps, normal versus abnormal, and you can see, hey, yeah, they don't look the same. You're looking for those red areas in the center, or it can be offset, but basically it's telling us, hey, look at this, this is not normal, okay? So it's pretty easy to look at and go, yeah, no, that's probably something I should draw the doctor's attention to, okay? It also does, again, curvature and thickness for a normal cornea for the person of that age, does those nice little maps for the doctor as well, okay? Obviously my references for this talk are right at the end of the handout. Any questions about any of that? No? All right. Well, I went through that really fast. I was worried I wasn't going to have enough time to do that and the practical stuff. So if you guys want to practice on each other, practice together, I am totally fine with doing that. I can give you a few tips and tricks with regard to how to take the image a little quicker, at least what works for me. But it is just practice that really helps, okay? The machine, does somebody want to be a volunteer for me? Okay, great. Can you get her chair? Thanks. All right, lovely Joanne. Thank you. So a good one would be appreciated at first, just so I can explain what I'm doing. All right, so as every machine that we use, there's the alignment issue. Patient has to be straight ahead. You want the chin rest to have their campus right next to that little black line.
No, that's fine.
So you can adjust the chin as needed to make sure the patient's in the right place. I start with the machine completely back towards me with the joystick as far back as I can possibly get. This works kind of just like the slit lamp. So just pull that joystick back, hold it as you're going in to see the patient. As you go in, you'll see the image of the eye come up here in the top right corner. You just want to keep lining it up so that you're mostly center as you go in. So scroll to the right to go up, scroll to the left to go down. And what I normally do is I get it so that I can see the cross section. So it's the bottom left corner. I can see that fairly clearly. I want to go in until it's almost touching, and then I worry about the top right corner and getting that centered, okay? So you want the red target to be lined up in the yellow target. And once I have that pretty darn close, I tell the patient, hey, we're getting close. Be prepared to keep your eyes nice and wide open, okay? So blink a few times for me, Joanne. I'm going to have you just make sure your chin's down and your forehead's forward. Blink again. Good. And just keep looking right there. Don't blink. Don't move. And now you can blink. Perfect. So you want to take a look at this as it's coming up. Thank you, Joanne. Take a look. Make sure that you don't see any obvious blinks. Sometimes information just goes missing. And you can sometimes get a really low lid or a really, like, their lower lid gets in the way or their upper lashes are getting in the way. You want to take a look at that, okay? You ideally would like this to be centered, but sometimes the machine will put the target off center, especially for irregular corneas. So you kind of just have to go with what the machine can give you. The biggest thing is you want to check to make sure that you have an okay here in the corner. Okay, if the machine's saying, yep, this information is accurate, then it's pretty accurate as long as the patient's looking straight ahead and positioned correctly. Okay, and again, if the patient's, yeah.
I've had it say model.
Uh-huh.
What does that mean?
I think it's having a hard time. I'm not 100% on this, but from my understanding is that it's not able to run the normal values is what I understand. It's not like.
Does that mean my scan's good? Do I retake it?
I would retake it.
Okay.
At least try one other time to see, make sure that that doesn't say fixation. You'll get that a lot. If the patient's watching the blue light spin around instead of looking straight ahead, you're going to get that fixation error. Anytime it's red, I absolutely will try at least one other image, maybe even two. Now, that's not to say that a red image is all you're going to be able to get for some corneas. It's really tough to get those PKP patients, and if the patient's not cooperating very well, not following instructions, it's really hard to get one. We'd rather have at least something than nothing. However, do be careful, because if it's red, sometimes it doesn't even generate your K values. If you don't have K values, it's a worthless scan. You wouldn't even need to send it. So if you're unable to get Ks, try the handheld. Again, those patients we're probably not going to do any kind of upgrade for, and it's probably an irregular or upset cornea anyway, okay? But for our normal screeners, you should be able to get a okay result, okay? Just looking at this general map, I can see, hey, her angles are open. It looks like she's fairly regular, and that we have our Ks here and an estimated amount of, so this is simulated Ks, and an estimated amount of astigmatism right there. So that gives me, if I didn't have an autorefractor, if I didn't have glasses to start from, this gives me a starting point for axis and for the amount of sill that she has. So it's a good tool to look at, and it's good to look at the autorefractor versus the Pentacam. Which one is closer? Then you get to know which one you can trust more, and which one's more accurate most of the time. But I can tell you again, when I have a PKP patient that I know is going to be a difficult refraction, I'm not going to start from the AR. I'm going to give my axis turned to this and to whatever this says, and I'm going to put my sill there. Okay, now the sill again may be totally off, but at least my axis should normally be in a pretty good position. Okay. Any questions about that? Okay. With regard to taking the image, down in the bottom right corner of the screen, you'll see it gives you hints as to which way to turn the joystick and whether or not you need to go in or out, left or right. I don't ever use that. I find it distracting. And I think if you can get used to just looking at where you are, it doesn't really matter what the controls are telling you what to do. As long as you know how to use a slit lamp, you should be able to control this without having to look at which way to turn the dial and which way to go, okay? And then again, I line up the cross section so that I'm almost on the line, get it centered, and then all I have to do is gently move forward and my image goes. So that's helpful. Also, so sometimes you'll see on the targeting map, the yellow target comes and goes. So you line it up almost perfect, and then the target goes away and it won't let the machine go. Artificial tears, it's having a hard time finding the reflections that it needs in order to get a good image, okay, or in order to align the image. So lean them back, put an artificial tear in, see if that helps. If not, line it up in the center, and you can force the machine to go. You hit the space bar. Space bar will make the machine take an image. Now, you're more likely to get something come back as a yellow or red in that area if you're telling the machine to go. But I have had some patients where I'm just not, the cornea is so irregular, it's just not focusing on any one point. It keeps jumping back and forth. I've put artificial tears in, still not working. So I can get an estimate again, just getting an idea of how irregular the cornea is, or if it's a PKP patient, is it this way or is it that way? The astigmatism, that gives the doctor something to go on, even if the numbers themselves are not perfect. Okay. You guys want to try and practice? Any questions?
I actually have a
Sure.
question. So when you said for PKPs that the doctor can tell, what was it, which sides are pulling?
Mm-hmm.
How can you tell on the map? Is it a certain color, or like, is it blue or red?
No, it has to do with the orientation of the astigmatism.
So it's wherever the axis
wherever
is.
the axes are, and
that's where it's pulling.
Mm-hmm.
Okay.
So, okay.
Isn't it usually red?
Yeah. So
Okay.
He's going to remove sutures from whichever area is the steepest, so that it flattens it out. If that makes any sense. So it'll be the red.
Okay.
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 So can you show in the in your
Oh.
package, or do you have a map or something you could
Show for the
show, like where you're talking about the red, the steepness?
Okay, well, if you are talking about, so this is a perfectly regular cornea, but if the, this would be the steeper area, so the doctor would potentially remove sutures here if this was the area of, obviously this is the steeper area, so we try to remove these in order to flatten out the cornea a little bit more.
Okay.
But you're never going to get a PKP patient that looks like this. So
Right.
the doctor uses the simulated Ks where it says the axis is, and kind of looks at the map to say, okay, they're mostly lined up in this direction with regard to that red line, giving you the steepest axis. It's mostly lined up here. He also takes into account where the axis is on the refraction. So super important that you at least attempt a refraction. If you're having a hard time, patients taking you around in circles, make sure you're noting that, because the axis is important when he goes to take sutures out, because he'll look at this and go, okay, this was estimating this, what was the refraction? If they match, he's more likely to remove sutures. If they don't, he's like, well, if this is 90 degrees different, I have no idea which way to go with this. Do I take them from here? Do I take them from there? So the refraction is still really important when you're working up those PKB post-ops. Okay. Any other questions?
Can I ask about the Balin? Is that how
Yeah,
you pronounced it?
sure.
So some of the texts have said some doctors like both all the time. And
Right.
maybe I'm mistaken, and so I've been doing both
Mhm.
every time,
Mhm.
just to make sure that it's there if they need it.
That's not a bad idea, but it does take time to do that.
Right.
If you can look at the cornea and go, yep, that looks pretty regular. There's no issues with thinning here. It's all nice and green. I can go, they're not going to want a Balin for this
Okay.
patient. Okay. But if there are weird things on the floor map, send a Balin. They're going to love that, because they'll have more information to talk to the patient. Do they have undiagnosed keratoconus? That the Balin again lets us look at that and say, okay, in more detail, this is your risk. Are you a totally fine patient, no risk? Are you a yellow patient? We need to watch you. Are you a red patient? You have this issue. Okay. There is one other thing that I wanted to show on this. Dr. Mayer has been using a change analysis, basically. They have one for posterior OCTs, those kinds of things. They also have one for the Pentacam. Lets us compare, okay, these were our last time numbers, these are our current, what's the difference? So it's really helpful for keratoconus patients. Is the keratoconus progressing? It's a part of the coding that we do. Is it stable? Is it progressing? We need to have that change analysis in order to tell. Well, we don't have to. You can look at the difference, but it's nice to have it all on one page. Makes it really nice and nice display for the patient. Makes it all in one page for the doctor. It's just one of the displays on here. It would be, if you go here, now I've only found this one. Here we go. Show compared to exams will give us that information. And you can select which Pentacam of the million you want to have as your A. So if I go back and I say, okay, the date from 11/15, I want to look at that test versus, maybe, takes a minute to load. If it's correct, let's try a different one. There we go. So this is from 3/9/17 versus today's measurement. What is the difference between A and B? Okay, so it gives us really good information. Again, lets the doctor see the progression numerically and in a nice pretty picture. Okay? So when the doctor, when you have a keratoconus follow-up, doctor will love you if you can print this out for them. This will not send via forum or DICOM. You actually have to print this one, which is, there's an option on there. You just hit print instead of DICOM. Okay? But yeah, that's that.
Where does it print to?
I know it prints to anterior segment. I do not know if it prints anywhere else.
And so should we add this to our protocol for keratoconus follow-ups?
Yeah, it might be helpful. Dr. Mayer will often just pop over here and take a look at it and print it himself because nobody knew how to do it. But yeah, if we wanted to add it to protocol after going over this, that would be fabulous because it does help him a lot. So that is the progression analysis for the Pentacam. Okay. Let me go back to today's. Any other questions? Issues? Anybody want to do some practicing on how to position things?
I'm gonna stop the video
Sure.
now. But if anybody has any more questions.
I just want to see what you're talking about when
Sure.
everybody else
Yeah,
is
yeah.
doing.
Sure.